Welcome to the funnel effect. What if the cure for the most stubborn, dangerous high blood pressure in the world isn't, just another pill? What if instead the answer is a microscopic rewiring of the nerves buried deep inside your abdomen, right around your kidneys?
Right, because usually when we talk about treating a chronic medical condition, there's this ingrained expectation of addition?
Yeah, exactly. You have a headache, you add an aspirin to your system, your cholesterol is high, you add a statin. It's this constant daily ritual of consuming something to keep the body's mechanics in check.
But today we're talking about solving a massive medical crisis, not by adding a chemical, but by permanently severing a biological communication line.
It's a complete paradigm shift.
Yeah.
And to guide us on this deep dive, we are pulling directly from a highly detailed, comprehensive source. The full title is Renal Denervation in 2026, Trial Evidence, Guideline Recommendations, and Implementation Strategies for Clinical Practice.
It's an incredible paper.
It really is.
Yeah.
And it was authored by Gianni Setza-Ashton, Louise Woodhams, Lakshini Herat, and Marcus Schleich, representing the Baker Heart and Diabetes Institute and the University of Western Australia.
Yeah, it's a remarkable synthesis of where we stand today. I mean, they've pulled together a century of medical history, incredibly intricate biological mechanisms, and the absolute cutting-edge clinical trial data that's actively reshaping cardiovascular medicine right now.
So our mission for you today is to explore this fascinating journey. We're going to map out the anatomy of the renal nerves, trace the absolute roller coaster history of renal denervation, which we'll refer to as RDN, and look at the very latest technologies battling for dominance in 2026.
Okay,
Let's unpack this.
let's do it.
Before we can really appreciate the elegance of this microscopic nerve-burning solution, we have to understand the sheer terrifying scale of the problem it's trying to solve.
Right, and the problem is hypertension. I mean, it remains the absolute leading modifiable risk factor for global cardiovascular mortality.
It is the silent engine, right?
Exactly. The silent engine driving strokes, heart attacks, and kidney failure worldwide. It doesn't have flashy symptoms, which is why it's so deadly. And while lowering blood pressure reduces that risk, the crucial caveat is that it only reduces the risk if the pressure stays lowered consistently, day in and day out.
Which brings us to a very specific, very vulnerable group of people. We aren't just talking about someone whose blood pressure spikes momentarily because they're, stressed in traffic or had too much coffee.
No, not at all.
We are talking about resistant hypertension. According to the source, this is defined as blood pressure that remains stubbornly, dangerously high, even when a patient is taking 3 or more complementary antihypertensive drugs at their maximum tolerated doses.
Yeah, and crucially, one of those drugs must be a diuretic, which is meant to flush excess fluid from the body.
Right.
That is a critical distinction to make. These are patients whose biological systems are actively fighting back against heavy pharmacological artillery. And this isn't a tiny, statistically insignificant fringe group.
How big of a group are we talking about?
This specific type of resistant hypertension affects between 5 and 10% of all hypertensive patients.
Wait, 5 to 10%?
Yes. When you consider that there are hundreds of millions of people with hypertension globally, 5 to 10% equates to a staggering number of individuals living with a ticking clock, walking around with pressures that threaten to blow out a vessel in their brain at any moment.
Wow. I want you to imagine the daily reality for these folks. The authors highlight something called the pill burden.
Oh, the pill burden is massive.
Right. For patients with complex hypertension, who almost always have other comorbidities like diabetes, high cholesterol, or previous heart disease, they might be taking 6, 7, or 8 different pills a day.
Easily.
And it's not just tossing them all back at breakfast. Some have to be taken with food, some on an empty stomach, some at night. The side effects, the chronic fatigue, the brain fog, the frequent urination from the diuretics, combined with the sheer exhaustion of scheduling it all, it just leads to incredibly high rates of non-adherence.
People just stop taking them because the treatment feels worse than the invisible disease.
Yeah, exactly.
What's fascinating here is how we have traditionally conceptualized the problem of high blood pressure. For the longest time, both doctors and patients have viewed it essentially as a plumbing issue.
Like pipes and pumps.
Right. We focus on the pump, the heart, and the pipes, the blood vessels. We prescribe beta blockers to slow the pump down or vasodilators to artificially widen the pipes. But the true master regulator, the organ that actually dictates your long-term blood pressure baseline, is the kidney.
I mean, taking multiple blood pressure pills every single day to artificially relax the blood vessels feels a bit like bailing water out of a leaky boat.
Hmm.
It works temporarily, it keeps you afloat for the afternoon, but it absolutely does not fix the hole in the hull.
That's a great way to look at it.
So if the kidney is the actual master regulator of this entire system, how exactly is it communicating with the rest of the body to drive up this pressure to such dangerous levels?
That brings us right to the nervous system, specifically the sympathetic nervous system.
Which is the fight or flight thing, right?
For context, yes, this is your body's fight or flight network. When your sympathetic nervous system activates at the heart, it raises your blood pressure acutely. Think about a jump scare or stepping on the brakes to avoid a car crash.
Right, your heart just pounds.
Exactly. Your heart races, your pressure spikes, but once the threat is gone, it comes down. However, when that sympathetic drive is directed toward the kidneys, it dictates long-term, sustained control of your fluid volume and vascular resistance.
Yeah, and it does this through a two-way street of communication. Let's really break down the lanes of this biological highway, because this is where the genius of the procedure lies.
Let's do it.
First, you have the efferent nerves. These are the signals traveling from the brain down to the kidney.
Correct. And when the brain sends a strong, continuous sympathetic signal down these efferent nerves, it essentially commands the kidney to go into chronic survival mode.
Survival mode, how?
Well, the entire length of the nephron, which is the microscopic filtering unit of the kidney, and you have millions of them, receives this innervation. The nerves tell the kidney to rapidly reabsorb sodium from the urine back into the blood.
Okay, and basic chemistry dictates that where sodium goes, water follows.
Exactly. So your body retains fluid, which massively expands your total blood volume.
Right, and more fluid in a closed system of pipes means higher pressure against the walls of those pipes. But that's not the only thing those downward signals do.
Far from it. The efferent nerves also command the kidney to constrict its own blood vessels, reducing renal blood flow. And most importantly, they stimulate specialized cells, the juxtaglomerular cells, to release a hormone called renin into your bloodstream.
Renin. That's the spark, right?
It is the chemical spark that ignites a massive biological cascade called the RAAS system, or the renin-angiotensin-aldosterone system.
That's a mouthful.
It is, yeah. But without getting bogged down in the intermediate chemical steps, the ultimate result of releasing renin is the production of angiotensin II, which is one of the most potent vasoconstrictors known to human biology.
So it forces the blood vessels to completely...
It forces the smooth muscles wrapped around your blood vessels all over your body to squeeze tight.
Okay, so let me get this straight. The brain forces the kidney to hold onto water, expanding the blood volume while simultaneously releasing a chemical that shrinks the pipes holding that blood.
Yes.
It's a recipe for an explosion.
It really is.
But
yeah.
that is just the brain yelling at the kidney. There is a second lane on this highway, which is honestly the most mind-blowing part of this entire paper, the afferent sensory
Oh,
nerves.
yes, the efferent nerves.
These are the nerves sending signals from the kidney back up to the brain. And according to the source, these sensory fibers make up only about 5% of the nerves around the renal arteries. Just 5%.
It is a tiny fraction of the neural wiring, but their influence on your systemic health is massive. These efferent sensory nerves are heavily concentrated within the wall of the renal pelvis, making them spatially optimized to act as stress receptors and injury detectors.
They're like an alarm system.
They are the kidney's distress beacon. When the kidney is damaged, say, by advancing chronic kidney disease or even just the wear and tear of long-term high blood pressure, these afferent nerves fire rapid panic signals up to key cardiovascular centers in the brain.
Where in the brain specifically?
Specifically, they target the paraventricular nucleus and the rostral ventrolateral medulla.
Which are essentially the brain's panic control rooms.
Exactly.
The text describes the kidney here as both the victim and the culprit. And that phrasing perfectly captures the tragedy of this disease.
He really does.
Because the kidney gets injured by high pressure. The sensory nerves panic and send distress signals to the brain's control room. The brain receives this panic, interprets it as a systemic whole-body crisis, and turns up the sympathetic drive to the entire body.
Right back down.
It sends signals back down to the heart to beat harder, to the blood vessels to constrict, and back down to the kidney itself to release more renin, raising the blood pressure even more, which further damages the kidney. It is a vicious, self-sustaining loop.
A perfect biological trap. And we can actually measure the systemic panic in real time.
Wait, really? How?
The paper discusses measuring muscle sympathetic nerve activity, or MSNA. Doctors can physically measure the sympathetic vasoconstrictor drive going into the skeletal muscles. In patients with chronic kidney disease, MSNA is visibly elevated.
So the brain is literally telling the whole body to clench its blood vessels.
Yes. And we know for an absolute fact that the failing kidney is the organ driving this whole body panic
How do we know that for sure?
because of transplant patients.
Oh, interesting.
Yeah. If you look at patients who have received a healthy kidney transplant, but the surgeons left their original failing native kidneys inside their body, which is common practice, their MSNA stays incredibly high.
The whole body is still clenched.
Exactly. But the moment a surgeon goes in and removes those failing native kidneys, physically severing those afferent sensory nerves, the MSNA drops dramatically. The distress beacon has been permanently turned off, and the brain finally tells the body to relax.
That is just incredible evidence. So if we know these specific nerves are the root cause of the problem, where exactly are they? Because if we are going to sever them, we need a map.
And the anatomical mapping is crucial for understanding why earlier attempts at this procedure failed and how we perform it successfully today.
Right.
Classically, old anatomy textbooks suggested the renal nerves formed a perfect, uniform ring, completely encircling the renal artery like a biological sleeve.
Like a little cylinder.
Yeah, but modern cadaveric studies have proven that is completely wrong. The nerves are not evenly distributed at all.
So how are they actually laid out?
They cluster heavily on the superior, the top, and the inferior, the bottom aspects of the renal artery. There are very few nerve fibers running along the front or back of the vessel.
Okay, top and bottom.
Furthermore, the density of these nerve fibers is highest proximally, meaning closer to the aorta, which is the main trunk line where the renal artery begins.
Got it.
As you move distally, traveling down the artery closer to the bifurcation where it splits into smaller branches to enter the kidney tissue, the nerves thin out significantly and dive deeper into the surrounding tissue.
Wait, I have to push back on the fundamental premise of this whole intervention for a second.
Sure.
Wait, if sensory nerves are signaling kidney damage, aren't they doing their job? Evolution put them there for a reason. Why would we want to destroy the body's natural alarm system? I mean, if my house is on fire, I don't smash the smoke detector.
It is a highly logical question and one that gives a lot of patients pause. To use your analogy, yes, evolution installed the smoke detector. In an acute survival scenario, say you are attacked by a wild animal and suffer a severe hemorrhage where your blood pressure drops to near zero, that alarm system saves your life.
Like clamping everything down.
Exactly. It clamps every blood vessel down to keep blood flowing to your brain and heart. But in a modern chronic condition like essential hypertension or chronic kidney disease, that alarm is essentially stuck in the on position.
So it's not a fire, it's a glitch in the wiring.
Exactly. It's like a car alarm blaring at maximum volume for 10 years straight because a leaf fell on the windshield.
That sounds exhausting.
It is. The acute survival mechanism becomes the very thing driving the chronic systemic destruction of your cardiovascular system. By burning these nerves, we aren't destroying a healthy, necessary alarm. We are silencing a malfunctioning one that is slowly killing the patient.
Okay, the logic is sound. The malfunctioning nerves are driving the deadly pressure, so we need to sever the connection. This leads us directly into a century of trial, error, and some truly wild medical history.
Oh, it's a fascinating history.
Right, because the concept of interrupting these specific nerves isn't a new product of the 2020s. The authors trace this all the way back to 1925.
That's right. Over a century ago, a pioneer surgeon named Adson performed what was called a thoracolumbar sympathectomy for patients with malignant hypertension.
Malignant hypertension. That sounds bad.
It was a death sentence.
Yeah.
We have to remember, this was the era long before effective blood pressure pills existed. If you had malignant hypertension, your blood vessels were going to rupture. To save people from dying of imminent strokes, surgeons would literally open up the patient's back, expose the spine, and physically sever the sympathetic chain ganglia with a scalpel.
It's essentially surgical butchery compared to what we do today.
It was incredibly invasive, incredibly painful, and carried massive risks. But to its credit, it actually worked to lower blood pressure.
Wow.
The underlying biological concept was proven right there in 1925. But the side effects of blindly hacking away at the sympathetic nervous system were often intolerable.
What kind of side effects are we talking about?
Severe postural hypotension, for one.
Meaning when you stand up?
Right. When you stand up, your sympathetic nervous system instantly constricts the blood vessels in your legs to fight gravity and push blood up to your brain. Adson's patients had that reflex completely severed.
Oh, well.
So they would stand up, gravity would pull all their blood into their legs, and they would instantly pass out. They also suffered severe bowel dysfunction and a very real risk of fatal surgical complications.
Yeah, that sounds rough.
It was an absolute last resort that was quickly abandoned the moment the first pharmacological blood pressure pills were invented in the mid-20th century.
Which makes sense. I mean, why undergo brutal spinal surgery when you can just swallow a pill?
Exactly.
But then, fast forward to the modern era, 2007, the medical community realizes that pills aren't working for everyone. So the first modern, minimally invasive, catheter-based renal denervation was performed in Melbourne.
A huge milestone.
No scalpels, no open backs, no long recovery times, just a tiny, flexible wire threaded up through the femoral artery in the leg, steered right into the renal artery, using radiofrequency energy to gently burn the nerves through the artery wall from the inside out.
And the initial results from those early proof-of-concept studies, known as the Simplicity HTN-1 and HTN-2 trials, were staggering.
How staggering.
We are talking about office blood pressure dropping by 27 to 32 millimeters of mercury systolic at 12 months.
Wow. 30 points.
In the world of hypertension management, a 30-point drop from a single 45-minute procedure is practically science fiction. The medical community was euphoric. It looked like the holy grail of cardiology.
But then came the crash.
Yes, the crash.
The Simplicity HTN-3 trial. This was the highly anticipated, rigorous, sham-controlled trial designed to prove to the FDA that this wasn't just a fluke.
And a sham control is vital here.
Right. It means some patients were put under conscious sedation, had the catheter inserted into their leg, heard the doctors talking, but no radiofrequency energy was actually delivered. It was fake surgery designed to completely rule out the placebo effect.
Right.
And at 6 months, HTN-3 failed to show a statistically significant difference between the treated group and the sham group. The hype just evaporated overnight. Companies abandoned their research programs.
If we connect this to the bigger picture, the failure of HTN-3 was actually one of the most important moments in modern cardiovascular research, entirely because of what it forced us to learn.
Let's explore that, because how does a procedure drop pressure by 30 points in one trial and fail completely in the next?
First, look closely at the sham group in HTN-3. The patients who received the fake surgery, the ones who had absolutely no nerves burned, saw their blood pressure drop by 11.7 millimeters of mercury.
Just from fake surgery?
Yes. That is an enormous, medically significant drop for doing absolutely nothing anatomical. It strongly suggests a massive Hawthorne effect.
Explain the Hawthorne effect for us in this context.
The Hawthorne effect is a psychological phenomenon where people change their behavior simply because they know they are being observed.
Oh, sure.
Remember, these trials targeted patients with resistant hypertension, many of whom were resistant because they had terrible pill fatigue and weren't taking their prescribed 7 daily medications.
And then suddenly they're in a high-stakes trial.
Exactly. Suddenly, they are enrolled in a high-stakes clinical trial. They have elite cardiologists checking on them constantly, calling them at home, asking about their pills. Just the act of participating made these non-adherent patients suddenly start taking their heavy pharmacological regimens perfectly.
So the treated group, who actually got their nerves burned, was suddenly competing against a control group that had completely changed their baseline behavior.
Exactly right.
The trial wasn't measuring the device against a true baseline. It was measuring the device against newly perfect medication adherence. But it wasn't just the patients acting differently, right? The doctors performing the procedure had massive technical issues too.
Precisely. The proceduralists simply lacked experience with this incredibly novel technique. Post-hoc analysis of the surgical logs showed that a vast majority of the doctors didn't achieve what we call a circumferential ablation.
Meaning they didn't go all the way around.
Think back to our anatomy discussion. The nerves are not a perfect ring. They cluster on the top and bottom of the artery. If a doctor only applied the radiofrequency energy to the front wall of the artery, they completely missed the majority of the nerves.
Oh, wow.
The patients in HTN-3 who did happen to get a complete circumferential ablation from highly skilled operators actually showed significant blood pressure drops.
Here's where it gets really interesting. Think of the Simplicity HTN-3 trial like a poorly executed recipe. If you're baking a cake and you don't distribute the heat evenly in the oven, if you don't get that circumferential ablation surrounding the artery, the cake is going to collapse in the middle.
That's spot on.
It doesn't mean the ingredients of the cake are wrong, or that baking cakes is a scientifically flawed idea.
Yeah.
It just means you, the baker, didn't execute the technique correctly.
A perfect analogy, and thankfully the scientific community realized exactly that. They didn't abandon the concept of silencing the nerves, they adapted their methods.
Which is great news.
This brings us out of the Dark Ages and into the renaissance of RDN, the modern wave of trials, and the fascinating technology showdown currently dominating the 2026 landscape.
Because the trial designs had to evolve massively after the HTN-3 disaster to ensure they were actually testing the physical device, not just the psychological behavior of humans.
Absolutely. The first major shift was entirely abandoning office blood pressure as the gold standard for measurement.
Because it's too unreliable.
Office readings are notoriously variable and unreliable. You rush to the clinic, you can't find parking, you are stressed about seeing a doctor in a white coat, and your blood pressure spikes.
White coat syndrome.
Exactly. Modern trials shifted exclusively to 24-hour ambulatory blood pressure monitoring, or ABPM. You wear an automated cuff on your arm for a full day and night. It measures your pressure while you eat, while you work, and critically, while you sleep, giving a true, undeniable mathematical average of your systemic pressure.
They also got incredibly strict about the medication issue to
Yeah.
eliminate that Hawthorne effect, right?
Very strict.
They implemented protocols for witnessed medication administration. Trial coordinators literally watched the patients swallow the pills, or they ran advanced biochemical assays on their blood and urine to prove the specific drug metabolites were actually in their system.
It entirely removed the guesswork of patient non-adherence.
So smart.
With these rigorous bulletproof controls in place, a new wave of trials emerged, and they tested several different energy modalities to find the best way to destroy these microscopic nerves.
Let's talk about those.
The first and most established is radiofrequency, which uses targeted heat. The spiral trials are the landmark studies here. To prove the concept beyond a shadow of a doubt, they ran the spiral off-med trial. They tested patients who were taken off all their blood pressure medications entirely.
Oh, wow.
It proved definitively that RDN works strictly on its own anatomical merits, dropping ambulatory systolic pressure by a modest but very real 4 millimeters of mercury.
And then the spiral on med trial tested patients who were kept on their typical complex blood pressure regimens, and that showed a 7-millimeter drop.
Correct.
Then there was the DENER-HTN trial, which was crucial because it proved that RDN has a 6-millimeter additive effect completely independently of optimized, perfectly adhered to medications. So we know targeted radiofrequency heat clearly works.
Yeah.
But in 2026, it has serious competition. Enter ultrasound.
Yes, the Radiance trials utilize the Paradise system developed by Recor. This system abandons heat and instead uses intravascular ultrasound.
Wait, ultrasound? Like for imaging?
Same basic technology, but different application. The catheter is placed inside the artery, but instead of touching the wall to create localized heat burns, it is surrounded by a tiny, fluid-filled balloon that cools the inner artery wall to protect it. Then, the transducer emits a 360-degree ring of high-frequency sonic energy that penetrates deep into the surrounding tissue.
That is wild.
The Radiance HTN Solo, Trio, and the massive Radiance 2 trials showed fantastic results. In fact, if you look at the raw data, ultrasound shows a slightly better short-term reduction, an extra 2 millimeters of mercury compared to the radiofrequency catheters.
But the source paper notes a fascinating catch there. That 2-millimeter advantage for ultrasound disappears entirely in head-to-head trials, like the Radiosound HTN trial, under one specific condition.
Right.
The radiofrequency method catches up completely if the doctors using it take the extra time to advance their catheters past the main artery and ablate the accessory arteries and the tiny distal branches, the smaller vessels deeper near the kidney tissue itself.
Exactly. It fundamentally comes down to anatomical coverage. Ultrasound energy naturally penetrates broadly. It creates a wider halo of effects, so it easily hits those nerves that have dived deeper into the main tissue without needing precise aiming.
Oh, I see.
But radiofrequency catheters are physically smaller, more flexible, and more maneuverable. This allows skilled proceduralists to chase those nerve bundles down into the tiny, branching distal vessels where an ultrasound balloon simply cannot fit. When ablation strategies are kept constant and thorough, both technologies are highly effective.
And then there's the wild card in this technological showdown.
Yeah.
The Target BP trials testing the Peregrine system, which uses alcohol.
Ah, yes.
This sounds wild. Instead of heat or sound waves, this system involves deploying 3 microscopic needles through the wall of the renal artery and literally weeping microdoses of dehydrated ethanol directly into the perivascular space to chemically denature and destroy the nerve proteins.
It is a completely different approach.
And it showed a 3.2 millimeter reduction compared to the sham at 6 months. Though interestingly, The trial noted that patients who were on 2 or fewer medications saw no significant benefit from the alcohol method.
This landscape of diverse results requires us to seriously calibrate our expectations. I want to spend a moment addressing the numbers we just discussed, drops of 4, 6, or 7 millimeters of mercury on an ambulatory monitor.
Yeah, let's talk about that.
To someone who remembers the flawed, euphoric early trials promising 30-point drops, hearing about a 6-point drop might sound incredibly small. It might even sound like a failure. But we have to look at this epidemiologically, not just individually.
Explain that for us. Why should we care about 6 points?
Because blood pressure is a game of microscopic margins over decades. On a massive population level, sustained, round-the-clock, single-digit drops in ambulatory blood pressure result in a massive reduction in the long-term risk of stroke, congestive heart failure, and myocardial infarction.
Just from 6 points.
Absolutely. A permanent 5 or 6-point drop across all 24 hours of the day, particularly during sleep when the pressure should naturally be low, is profoundly clinically relevant. It saves millions of lives and billions of dollars in emergency cardiovascular care.
And beyond the population statistics, I want you to imagine the psychological relief for the individual patient. If a 30-minute ultrasound or radiofrequency procedure can permanently lower your absolute baseline pressure by 7 points, that might literally be the difference between taking 3 heavy medications a day versus just 1.
Exactly.
The sheer relief of taking 2 fewer pills every single day for the next 30 years of your life is an immense victory for daily quality of life.
That is precisely the ultimate goal, reducing risk and reducing the daily burden of disease. But of course, that entire premise assumes that the biological effect is permanent.
Right.
Which brings us to one of the most intense, heavily researched debates in this entire field, the durability question.
Right. It's the natural skepticism anyone would have.
Yeah.
We know the human body is an incredible, resilient healing machine. If we use heat, sound, or alcohol to violently destroy these microscopic nerves, won't the body just recognize the anatomical damage and grow them right back? I mean, it heals cuts on our skin. Surely it tries to heal severed nerves.
It was a very valid, widespread fear in the scientific community, initially sparked by fascinating data from kidney transplant studies.
What did they find?
When pathologists took transplanted kidneys and looked at the tissue under a high-powered microscope months after the surgery, they found clear histological evidence of nerve sprouting and periadventitial nerve regeneration.
They're growing back.
The severed nerves were physically growing, sprouting new tendrils, trying to reach out and reconnect across the surgical gap. This led to a huge scare that the blood pressure-lowering effects of RDN would only last a year or two before the newly grown nerves reestablished the panic circuit, bringing the hypertension roaring back.
But the paper explicitly clarifies a major biological concept here. Physical presence does not equal functional capability. Just because you see a nerve under a microscope doesn't mean it works.
Exactly. It is one thing for a nerve fiber to blindly sprout into empty tissue. It is an entirely different biological requirement for that complex nerve to successfully navigate the anatomy, integrate perfectly into the existing network, establish functioning chemical synapses, and flawlessly conduct regulatory signals back to the brain.
So how did they test if they actually worked?
To test if these new nerves actually worked, researchers used lower body negative pressure responses.
Let's explain what that is, because it sounds like a torture device from the 1800s.
It's quite safe, but it's an ingenious functional test. You seal the lower half of a patient's body in a chamber and create a negative pressure vacuum.
Okay.
This forcefully pulls and pulls their blood down into their legs, drastically reducing the blood returning to the heart. It tricks the body into thinking it is experiencing massive sudden blood loss. A healthy, fully innervated kidney will immediately detect this terrifying drop in central pressure and trigger a massive sympathetic reflex to clamp the blood vessels down and save the brain. But in those transplant patients with those regenerated nerves we saw under the microscope, that sympathetic reflex response is markedly reduced or absent entirely.
So the new nerves don't trigger the alarm.
The newly sprouted nerves are essentially biological junk wire. They don't actually function like the original native network.
So the histological fear, the visual of the nerves growing back, didn't translate into functional failure. The wires look connected, but there's no electricity running through them.
That's a great way to put it.
And we don't even have to rely on transplant proxy data anymore, because after years of waiting, we finally have the long-term, real-world observational outcomes. The text highlights a decade of follow-up, which is arguably the most reassuring piece of data in the entire document. We're looking at patient follow-ups extending out to 9 and 10 years after their initial procedure.
The longevity of this specific data set is a triumph for the field. 10 years post-procedure, we see robust, deeply sustained effects.
What are the numbers?
Specifically, the registries report an average 12.1 millimeter reduction in systolic pressure and an 8.8 millimeter reduction in diastolic pressure on ambulatory monitors at approximately 9 years out.
That's incredible.
That is a permanent reshaping of the patient's cardiovascular profile.
And crucially, that massive drop wasn't achieved by the patient simply aging and being prescribed more pills over the decade. The data actually shows a statistically significant reduction in their daily defined pill burden. They had significantly lower blood pressure on fewer toxic drugs a full decade later.
I do have to add a neutral, rigorous scientific caveat here, as the authors rightly point out in their methodology section.
Sure.
Long-term follow-up registries of this nature suffer from inherent, unavoidable selection bias. The patients who felt better, who had incredibly positive, life-changing responses to the initial RDN procedure, are far more likely to enthusiastically consent to coming back to the clinic for testing 9 years later.
Oh, that makes sense.
Those for whom the procedure failed likely dropped out of the registry entirely. Furthermore, these long-term registries lack non-RDN control groups over that decade because it is unethical to keep a sham group untreated for 10 years just for comparison.
So, what does this all mean? Even taking those very real scientific caveats into account, the overwhelming weight of the functional testing and the observational data over a decade points to one incredibly hopeful conclusion. RDN is not a temporary 2-year Band-Aid. We are talking about a potentially permanent structural reset of the cardiovascular thermostat.
Which is exactly why the major international medical guidelines have finally caught up to the science. But that brings us from the theoretical realm into the practical reality of modern clinical practice.
Right.
If this procedure works so well and it lasts for a decade, why isn't every single person with high blood pressure getting it tomorrow? How does a doctor actually decide if you, listening right now, are a proper candidate?
Welcome to the clinical funnel. The text dedicates a significant portion to patient selection strategies because it turns out it's actually quite difficult to predict who will be a super responder to this nerve burning and who might not respond to it at all.
It is genuinely fascinating what doesn't matter in this equation. You might intuitively think that a patient's body mass index or their biological sex would play a massive role in how their nervous system responds, but the rigorous statistical data shows that those factors have very limited utility in predicting a successful long-term blood pressure reduction.
So if weight and sex don't predict success, what does?
First and foremost, incredibly high baseline blood pressure. The absolute higher your pressure is when you walk in the clinic door, the bigger the numerical drop you are likely to see.
Okay.
But more intricately, cardiologists now look for highly specific physiological markers that scream the patient has high sympathetic drive.
The source material specifically mentions a combination of a high resting heart rate combined with a lack of nighttime BP dipping. Let's explain what dipping is because it's a vital concept.
Yes, very important.
Normally, when you go to sleep, your body powers down. You aren't moving, you aren't stressed, and your blood pressure should naturally dip significantly. If you wire someone to a 24-hour ambulatory monitor and their pressure stays terrifyingly high all night long while they are dead asleep,
That is a massive flashing red flag. It indicates that the sympathetic nervous system is trapped in the on position, constantly driving the cardiovascular system into overdrive even during periods of deep rest when it should be recovering.
oh, wow.
Patients with this specific biological profile, a high resting heart rate, coupled with non-dipping nighttime pressure, predictably see much, much better results from RDN. It works so well for them because the procedure is directly targeting the exact neurological mechanism of their specific disease variant.
But there is another crucial mechanical factor doctors must test for: vascular stiffness. They test this using a diagnostic tool called pulse wave velocity.
Yes, pulse wave velocity measures exactly how fast the physical pressure wave from your heartbeat travels down the length of your arteries.
Like a wave in a pool.
Exactly. Imagine a wave moving through water. If your arteries are soft, young, and flexible, they absorb the shock of the heartbeat, and the wave travels relatively slowly. But if your arteries are heavily calcified, rigid, and stiff from decades of disease acting more like old lead pipes than rubber hoses, the pressure wave travels incredibly fast, slamming into the organs.
And if your hypertension is driven purely by the physical fact that your pipes are rigid and calcified, rather than by overactive panic signals from the nerves, then zapping those nerves won't magically make the steel pipes flexible again.
Precisely. Patients with a lower pulse wave velocity, meaning they still have somewhat elastic, less stiff arteries, respond significantly better to nerve ablation. If the root pathology is purely structural vascular decay, a neurological intervention will naturally have a highly muted effect.
So let's walk through the actual step-by-step diagnostic funnel a patient goes through.
Okay.
Step 1. Your doctor officially confirms you have blood pressure consistently above guideline targets despite actively taking 3 or more different pharmacological agents, including a diuretic. Step 2. They must rigorously exclude white coat syndrome.
This step is critical to avoid unnecessary surgeries. Some people only have high blood pressure because they are subconsciously terrified of being in a clinical setting around doctors in white coats. An ambulatory monitor worn at home completely rules this out. We absolutely cannot perform permanent structural interventions on patients whose only issue is situational anxiety-induced office spikes.
Step 3. Exclude non-adherence. We have to be biologically certain you are actually taking the pills prescribed before we declare you resistant.
Right, using those witness protocols or assays.
Step 4 is investigating secondary causes. High blood pressure is usually essential, meaning it has no single obvious cause, but occasionally it's caused by a highly specific, totally curable underlying issue. The text mentions screening every patient for primary aldosteronism, obstructive sleep apnea, and renal artery stenosis.
This is basic medical diligence. If a patient has severe sleep apnea, they are choking in their sleep, which causes massive blood pressure spikes. That patient needs a CPAP machine to breathe, not a renal denervation procedure.
That makes complete sense.
Or if they have renal artery stenosis, which is a literal physical plaque blockage in the artery supplying the kidney, they need a mechanical stent to open the pipe, not nerve ablation. We must definitively rule out these secondary curable drivers first.
But if you diligently pass all those diagnostic checks, you finally arrive at step 5, shared decision-making. And this is where the major clinical guidelines for the European Society of Hypertension in 2023, the European Society of Cardiology, and the American Heart Association all powerfully align.
They do.
They officially endorse RDN, giving it a Class 2, Level B recommendation for resistant patients with an eGFR, which is a measure of kidney filtration function, greater than 45.
This raises an important question about how we fundamentally categorize and treat complex diseases in the 21st century. The guidelines deeply emphasize the phrase shared decision-making. This isn't just a paternalistic doctor blindly prescribing a surgical treatment. It is an in-depth, nuanced conversation about the patient's holistic preference. A patient might look at their life and say, I am 50 years old. I simply do not want to manage the side effects and the schedule of taking 4 heavy medications every single day for the next 35 years of my life. Patient preference for a permanent device-based intervention over a lifetime of exhausting pharmacological burden is now a officially recognized, scientifically valid medical pathway.
So the science is settled, the guidelines are written. The main barrier remaining isn't the biology, it's economics.
Yes, economics.
While it is fully approved and rolling out in the USA, the text explicitly notes that outside the US and Europe, the Asia-Pacific, and other massive global regions, there is still a widespread lack of reliable regional reimbursement. Insurance systems and national health services are notoriously slow to adapt to new paradigms, which remains the primary roadblock preventing widespread clinical implementation globally.
It is a tragically common lag in modern healthcare. The brilliant science proves the efficacy, the international medical guidelines enthusiastically endorse it, but the bureaucratic and financial infrastructure takes several agonizing years to catch up and actually pay for it.
But assuming that bureaucratic financial dam eventually breaks, where is this technology heading next? Because if we have definitively proven that silencing these specific kidney nerves safely lowers systemic blood pressure, it begs a massive, exciting question. What else can sympathoinhibition fix? We are moving into the cutting edge of 2026, beyond blood pressure.
The potential applications are expanding at a rapid pace because systemic sympathetic overdrive is not unique to hypertension. It is a hallmark of many cardiovascular diseases.
Like what?
Let's look closely at atrial fibrillation, or AFib. This is an erratic, chaotic, often dangerously fast heart rhythm. We know AFib is primarily driven by structural remodeling and scarring of the heart tissue, but it is heavily exacerbated by a heightened, panicking cardiac sympathetic drive.
The standard physical treatment for severe refractory AFib is pulmonary vein isolation, or PVI, where an electrophysiologist goes into the heart and actively burns tissue to block the chaotic electrical signals from spreading. It's a localized fix.
Sure.
But the text notes a frustrating reality. 20 to 40% of patients still have AFib recurrences even after a successful PVI procedure. The localized fix isn't enough.
So visionary researchers asked a brilliant question. What if we combine PVI with RDN?
Treat the heart and the kidney.
Yes. We fix the localized electrical pathway in the heart, and we simultaneously calm down the global sympathetic nervous system by treating the kidney nerves. The landmark Eradicated trial tested this exact hypothesis and showed that this dual combination was statistically superior to PVI alone in preventing recurrences.
Oh, that's huge.
Now, for complete transparency, it is important to note that two more recent, somewhat smaller trials, HFIB 1 and 2, had mixed results showing non-significant reductions. But when you look at the overall meta-analyses pooling all the data, it still strongly supports the combined approach. It is an incredibly promising new frontier for electrophysiology.
Then we have heart failure, which is a devastating progressive condition. The text splits this into two major clinical types: heart failure with reduced ejection fraction HFrEF and heart failure with preserved ejection fraction HFpEF.
Let's break those down.
Right.
In HFrEF, the actual heart muscle is physically weak, flabby, and struggling to pump enough blood out to the body. The body's biological response to this terrifyingly low blood output is to massively crank up the sympathetic nervous system to force the dying heart to work harder and beat faster.
It's like whipping a tired horse.
Exactly. This sympathetic overdrive ultimately damages the failing heart even faster, accelerating the patient's decline. Trials have shown that performing RDN on these specific patients leads to measurable short-term improvements in how far they can walk in exactly 6 minutes, which is a standard quality of life test.
That's amazing.
It also reduces NT-proBNP in their blood, which is a biochemical marker directly indicating heart muscle stress. It even shows a modest but real physical increase in the heart's ejection fraction, its pumping power at 6 months.
But it doesn't seem to work at all for HFpEF, the preserved ejection fraction type. The text notes those specific trials were halted early because they showed absolutely zero difference between the treated and sham groups.
Exactly. And the reason why is a beautiful lesson in targeted medicine. HFpEF is driven more by the severe physical stiffness and thickening of the heart muscle, preventing it from filling properly, rather than massive sympathetic overdrive.
Okay.
The underlying biological mechanism of the disease simply doesn't match the neural mechanism of the therapy. Burning nerves won't make a stiff heart flexible. It brilliantly highlights the absolute necessity of precision medicine. We cannot blindly apply a great tool to the wrong problem.
We also have to talk about chronic kidney disease itself, which is often intimately tied to hypertension. We know RDN lowers blood pressure, but there is a glaring, obvious safety concern here. Does dragging a hot catheter into the artery of a failing kidney and actively burning the nerves right next to it damage the fragile organ further?
It's the most common question nephrologists ask.
Right. What does the data say?
The long-term observational data is overwhelmingly clear. No, it does not. At 3 years post-procedure, in patients with established stage 3A and 3B chronic kidney disease, they see safe, sustained blood pressure lowering without any accelerated worsening of their kidney function compared to standard decline.
That is incredibly reassuring.
There are even small, highly promising preliminary studies showing systemic sympathetic benefits for patients whose kidneys have failed completely and are on full dialysis.
And we actually see structural benefits to the heart architecture, too, beyond just the electrical rhythm. Left ventricular hypertrophy is a deadly condition where the left wall of the heart muscle thickens dangerously because it spends years pumping against high pressure like a bodybuilder lifting weights.
Right.
RDN appears to significantly reduce this left ventricular mass. But what is truly mind-blowing is that this physical reduction in heart mass seems to happen independently of the actual blood pressure drop.
It's fascinating.
The direct sympathoinhibition, just the act of turning off the body's panic signal, somehow allows the heart muscle to independently relax, stop fighting, and favorably remodel its own physical structure.
There are even tantalizing hints at profound metabolic benefits.
Like diabetes.
Well, the data on glycemic control, how the body manages blood sugar in diabetes, is currently mixed and heavily debated. The DREAMS trial, for instance, didn't show major changes in glucose metrics, but the underlying physiological logic remains incredibly sound because the sympathetic nervous system heavily mediates how the liver produces and releases glucose into the blood.
Oh, wow.
The authors of the source paper provocatively speculate that the true metabolic breakthrough of the future might require a combined therapy, simultaneously performing both hepatic, meaning liver, and renal denervation to completely quiet the body's metabolic stress response.
Wow. Denervating multiple major organs via catheters to cure systemic metabolic disease. That is a wild science fiction level look into what medicine might look like in the 2030s.
It really is.
But looking back at exactly what we've covered today, the journey to get here is already one of the most incredible arcs in medical history. We started a century ago in 1925 with a surgeon named Adson literally opening patients' backs with scalpels to violently sever ganglia, a brutal, highly dangerous, but conceptually brilliant attempt to save lives from malignant hypertension.
And from those bloody origins, we moved through the 2007 catheter breakthroughs. We weathered the completely crushing, field-altering disappointment of the Simplicity HTN-3 trial.
We learned painful lessons from our own procedural mistakes.
Right, and we radically refined our clinical trial designs by adopting 24-hour ambulatory monitoring and strictly witnessed medication protocols to eliminate human behavioral bias.
And now, sitting here in 2026, we have a scientifically validated, strictly guideline-endorsed, minimally invasive outpatient procedure using highly advanced radiofrequency heat, deep penetrating ultrasound, or even chemical alcohol ablation.
It's amazing progress.
It offers a sustained, incredibly safe, and potentially completely permanent off-ramp for patients who have spent decades hopelessly drowning in complex, exhausting daily regimens of blood pressure medications.
It represents the ultimate evolution of thought in cardiology. We have moved from viewing resistant hypertension purely as a chemical imbalance that can only be temporarily managed by swallowing daily pills to finally recognizing it as a tangible neuroanatomical feedback loop that can be physically, permanently corrected with advanced engineering.
Which leaves us with a profound thought to carry forward as we look at the future of healthcare. If we are actively learning that we can essentially cure a massive systemic total body disease, like resistant hypertension, by selectively silencing a single, localized, microscopic nerve pathway buried deep in the abdomen.
It makes you wonder.
It really does. What other chronic, intractable diseases of modernity that currently plague us are just waiting for us to map the nervous system, find the right microscopic wire to cut, and cure the root cause, rather than just prescribing yet another daily pill to mask the symptoms? Thank you for watching The Funnel Effect.